Let's get started. All right. Welcome, everybody. This is the VCU Department of Internal Medicine Grand Rounds. Today is one of our 4 CPC cases hosted by the Internal Medicine Chief Residents. Thanks for being here, both online and in person. So if anybody needs a copy of the State of the Department address from last week, please email us. We are sharing the link on select cases, but we will not be posting that link online on the public YouTube forum. So, all right, let's get started. So let me call Rose up here. Rose is one of our chief residents going into geriatrics. Yes, so she's going to introduce Dr. Tim Johnson, who's going to be our case discussant, and get us started. All right.
Hi, everyone. I'm Rose. I am going to be introducing Dr. Johnson. So Dr. Johnson attended medical school and internal medicine residency at VCU and has served as an academic nocturnist since graduation in 2018, supervising the internal medicine residents on their night medicine rotation. He's the director of night medicine and associate program director for POCUS for the residency program. And we'll get started with the case. There we go. So our case today is a 37-year-old woman who presented to the ED with sudden onset atraumatic left face, arm, and foot numbness, pain, and weakness for the past week. She described it as numbness and crampy pain generalized across the left side of the face, the left foot up to the ankle, the left arm from the hand to the shoulder. She was doing house chores at the time of onset of her symptoms. Symptoms have been transient, occurring 10 to 30 times daily, lasting 5 to 10 minutes each, with incomplete resolution between episodes. They were intermittent with unclear trigger and were non-positional. She also had associated, quote, buzzing noise in her left ear when people around her were conversing, but no headaches. Notably, in the past few months, she had several transient episodes of similar face numbness, as well as confusion, which was described by her husband as not making sense when speaking, and also sudden flashes of images in her right peripheral vision, left foot, and hand tremor. However, these symptoms spontaneously resolved or improved, and she didn't go to the ED. A brief review of system, pretty unremarkable, no fevers, chills, no blur or double vision or pain with eye movements, no chest pain, shortness of breath or cough, no GI symptoms, no unintentional weight changes, no generalized shaking, urinary or bowel incontinence, no easy bruising or lymphadenopathy, no notable rash, no anxiety or depression. A little more past medical history. She has a history of type 2 diabetes, hypertension, hyperlipidemia, history of appendectomy, family history notable for breast cancer in the mother, and asthma in sister, otherwise no family history of seizures. Social history, she immigrated from Mexico in 2005 with no notable health concern prior. She's primarily Spanish-speaking, cooks all her meals, and does not eat raw food. No recent animal or insect bites or any outdoor camping. No smoking, no drug use, no alcohol use. At home, she takes metformin, glimepiride, vitamin D, atorvastatin, no supplements or over-the-counter medications, no drug allergies. On exam, her vitals, her temperature is 36.7, blood pressure 114/71, heart rate 80, respiratory rate 15, and she's starting 100% on room air. On exam, she's awake and alert while appearing, no acute distress. She answers all questions and follows commands appropriately. Her HNT exam is notable for pupils were equal and reactive to light, conjugate gaze, eye movements are intact without nystagmus, no visual field cut, no neglect. She does have a mild left nasolabial fold flattening, but no tongue deviation. Her cardiovascular exam is normal with regular rate and rhythm, normal S1, S2, no murmurs. Respiratory exams clear to auscultation. Her neuro exam, she has intermittent involuntary movements for left hand and forearm, both rhythmic and non-rhythmic at times, and not suppressible or controllable by the patient. She has intermittent rhythmic jerking of the left arm, which what appears to be posturing of the left hand. There's mild weakness of the left arm and shoulder abduction, 4 out of 5, Elbow flexion and extension, 4 out of 5. Mild leg weakness and hip flexion, 4 out of 5. Otherwise, strength is 5 out of 5. She has decreased sensation in the left arm and leg compared to the right, and her reflexes were 2+ throughout. A little laboratory data. Her CBC white count is 12.5, hemoglobin 4.0, platelets 273. She does have a neutrophilic predominance with her leukocytosis. Notably, a few days later, her white count resolved and is 8.4. Other lab data, BMP is notable for sodium of 132, potassium 3.9, chloride 99, bicarb 22, and ion gap of 11. Glucose is elevated to 21, BUN is 19, creatinine is 0.79, calcium 8.7, and her hepatic panel AST and ALT are normal, largely unremarkable. Alk Phos 24, protein 7.1. Urine pregnancy test was negative, and drug screen is negative, including Tylenol level, salicylate level, and ethyl alcohol. Her UA showed a lot of glucose and 40 of ketones, but otherwise non-infected and no blood. Her hemoglobin A1C was 8.3. Her lipid panel total cholesterol was 210, triglycerides 71, HDL is 51, and LDL is 145. TSH is 2.3. Ammonia level is 22, which is normal. Vitamin B12 and folate are both normal. HIV is negative. Her TB quant is negative, and her syphilis non-reactive. Her acute hepatitis panel, viral panels, is all negative, non-reactive. Her serum crypto antigen was negative as well. Fungital is negative. Her lactic acid was elevated at 3.2 on admission, and notably a few days later, it was elevated at 3.6. EEG, she got a continuous EEG, which showed mild interhemispheric asymmetry with a loss of faster frequencies in the right hemisphere. Otherwise, no epileptiform discharges or seizures. She got a CT head non-con initially, which showed ill-defined hypodensity in the right frontotemporal region. There's no intracranial hemorrhage, extraaxial collection, or mass effect, and no evidence of acute infarct. She got a CTA head and neck, which showed no large vessel occlusion, no perfusion defects, and again noted that hypodensity in the right frontotemporal region. So she got an MRI. MRI head with and without IV contrast, which showed persistent extensive flare T2 hyper intense signal and mild diffusion restriction throughout a majority of the right temporal, occipital, lateral, parietal lobe. Possible subtle involvement posterior mesial left temporal lobe, anterior occipital lobe junction. Otherwise, no associated parenchymal enhancement or hemorrhage. She did get an LP. In her CSF studies, her cell count showed a RBC of 4 and WBC of 3. Otherwise, it looked clear. Protein 39 and glucose elevated at 112. Her culture was negative for any growth at 48 hours, and her cytology was negative for any malignancy. Additional CSF studies, including a very comprehensive meningitis pathogen panel, which was all negative. HSV was negative, VZV negative, crypto negative. Her aquaporin 4 antibody was negative, syphilis negative, and Lyme negative. And with that, I'm going to pass on to Dr. Johnson.
Hang tight 1 second.
All right. Thanks, Rose, for the introduction. Happy to be here. For those that don't know me, I'm an academic nocturnist, so usually working with the residents at night. For those that do know me, you're probably wondering what I'm doing here during the daytime. That's the most common question I get, and especially why I'm not dressed in scrubs. But it's good to see a lot of familiar faces. I thought it was just going to be me and Dr. Gear for a little bit.
Need to fix it's not sharing with
Oh,
the
okay.
Zoom. Sorry, technical difficulties today. Need to make sure our online folks can see and hear you. There we go.
All right. All right. So I like to think of myself as joining the pantheon of great doctors before me who have been sought out for their expertise. Either that or Rose is just desperate to find somebody to do this case. This is not an official endorsement of any of these doctors, except for maybe Indiana Jones. I mean, he's great. All right, so let's go over the case. Let's break this down. This HBI is quite complex, so I like to first look at it, trying to decipher the timeline to begin with. It looks like things got shifted a little bit. Sorry, excuse that. But looking at her symptoms and the timing of them, so she's currently presenting after these have been occurring for about 1 week. They're occurring daily, about 5 to 10 minutes each, 10 to 30 times per day, and having incomplete resolution between episodes. Prior to that, she was having symptoms intermittently over the past few months. So it seems like more of a chronic nature with now an acute worsening. Now, thinking about her symptoms in particular, and I don't know why all these got shifted to the side. Interesting. All right. We'll take that off for a second to make that easier. So her symptoms are primarily left-sided. So left arm, left face, and foot numbness, pain, and weakness. So a variety of different neurologic implications there with both motor and sensory and multiple different extremities and spinal levels, we should say, or dermatomes. These are also in conjunction with, put this right back on, some issues with hearing, it sounds like, buzzing noise in her left ear, and then issues with her vision, flashing lights in her right peripheral vision, and then some foot and hand tremors as well. She also has what sounds like some higher cortical issues with episodes of confusion, and then talking in what sounds like not making any sense, which sounds like a variation of aphasia. So when I step back and I think about this presentation, it seems more likely that this is, even before seeing the imaging, it's more of a central neurologic process, something that might be originating in the right cerebral hemisphere and then having symptoms on the contralateral side with her unilateral numbness, pain, and weakness down the left side. It's more likely that than something that may be affecting multiple different spinal levels or a more peripherally based issue. When I look at her right peripheral vision issues, this is interesting because if you think about an issue that would be in the right cerebral hemisphere, and if it's affecting the occipital lobe, thinking about how that pathway crosses over in the optic chiasm, you would expect issues with the left peripheral vision. So not quite sure what to make of that. And maybe there's an issue somewhere else, like in the opposite occipital lobe, or maybe even in the optic nerve. So looking at our review systems, denies fevers and chills, that stands out because just thinking about infectious pathology, even though I have a lower suspicion for that, noting her chronicity of symptoms. Denies blurred or double vision, pain with eye movements. This stood out to me with her visual complaints. When you think about something like optic neuritis, usually you're going to see pain with eye movements, and she doesn't have any visual deficits as well. Denies unintentional weight loss, so thinking about the chronicity and something that may be more insidious if as far as looking at malignancy. And then denies anxiety or depression. So this was interesting because despite the slew of very impressive neurological complaints that she has and deficits, she doesn't have any neurocognitive or psychiatric dysfunction. Her past medical history is notable for a variety of vascular risk factors. And then family history real quick. So nothing really stands out that would be contributory so far. Immigrated from Mexico in 2005. So this being over almost 2 decades ago, I would think that this is probably not contributing to her presentation unless it was more of an insidious pathology, maybe something like tuberculosis, which we've already seen has been negative. She cooks all her meals, does not eat raw food. So what we're getting at here is potentially like neurocysticercosis, but we didn't, we'll talk about the imaging, but does not eat raw food. And then you may think about like variant Creutzfeldt-Jakob, aka mad cow disease, though interestingly enough, the sporadic cases of this account for most of that. No recent animal or insect bites, no outdoor exposures. So just thinking about other transmissible vectors. And then looking at her physical exam. So she's afebrile and her vitals are stable. Now, coupling that with the chronicity of her symptoms, that makes me less concerned for infection, knowing that this has been going on for a few months and she's still presenting with stable vitals. She has left nasolabial fold flattening, no tongue deviation. And then on her neuro exam, she has these involuntary movements of her left arm and left-handed forearm, and they're not suppressible, and she's got rhythmic jerking. So it seems like some type of myoclonic jerks, maybe like a focal seizure-like activity. She has posturing of that left hand. Not sure if it's decorticate or decerebrate, but this indicates likely a major CNS insult cerebrally. And then she's notable for marked deficits on the left side. Reflexes are 2+ throughout. I'm going to take that with a grain of salt, thinking about potential upper motor neuron pathology. You may expect hyperreflexia. And notably, we don't have a Babinski test here. So she had a white count that did normalize after a few days. It's unclear if she had any interventions that resulted in that. And then her bicarb is normal with a lactic acidosis that has persisted over a few days. Anion gap calculated to be normal as well at 11. So she has this persistent lactic acidosis without a concurrent systemic metabolic acidosis that we could discern. We don't have a pH or a gas, but from the data I have. HIV is negative. So thinking about just immunocompromising conditions in general. And then we've already got some negative infectious tests, including the TB. So CT, and I apologize again that these, for some reason, all got shifted in the email over. CT has ill-defined hypodensity, no mass effect, no evidence of acute infarct on the CT itself. And then she's got no vascular occlusions, no perfusion abnormalities. So making me less concerned for like an actual vascular etiology for a stroke. And then most notable is her MRI brain. So this is really where the money is at. So she has this extensive T2 flare hyperintensity, and it's taking up most of the right hemisphere. There's cortical diffusion restriction, but notably no parenchymal enhancement. And then her EEG, I recognize that the most important thing is that there's no epileptiform abnormalities. Her lumbar puncture in general is normal. So her glucose is elevated, but if we recall, her blood glucose was markedly elevated in her serum as well, and it's unclear what it was exactly at the time of this test. And then she's got a variety of bacterial and viral pathogens that were tested for, all negative. Cytology was negative for malignancy. So all those are reassuring, even though I had that kind of lower on my list. What stands out here is this negative aquaporin 4 IgG. And if you're like me, you're like, what is that? And so we'll talk about it in a minute. All right, so here's my summary statement, just kind of putting it all together. So she's a 37-year-old woman. She has chronic relapsing and remitting unilateral polysymptomatic progressive neurologic dysfunction. Her exam's concerning for focal motor seizures and posturing, possibly from upper motor neuron insult. And then labs show a persistently elevated lactate nod without a systemic metabolic acidosis. Lumbar punctures, fairly normal. An MRI shows extensive T2 hyperintensity of that right cerebral hemisphere with cortical diffusion restriction. So normally with this end of that summary statement, I would give you what I think is most likely as the diagnosis if I was writing my H&P and passing off this patient. But the diagnosis, the differential is quite wide still with the information we have. So trying to break it down into a few categories here, starting with infectious. Like I mentioned, I'm less concerned about that. We've had quite an extensive workup so far, and already coupling that with the chronicity of her symptoms and stable vital signs, I don't have concern for us missing a certain infectious pathogen. Neurocysticercosis, we did not see the trademark cystic lesions on the MRI. She's not eating any uncooked raw food. We didn't see anything consistent with an abscess on our MRI as well. And then Creutzfeldt-Jakob, I think, is still something to consider as far as why she's having a rapidly progressive neurologic decline. But there are some things that don't fit with that we'll talk about. CNS lymphoma, once again, not seeing a more discrete mass with Brinkmal enhancement or rim enhancement. And then she had negative cytology on her lumbar puncture, makes that less likely for me. And then same with the high-grade glioma with some of the characteristic findings on our MRI, though I did see that there's cases of certain astrocytomas, which can present like our patient's imaging findings that are more diffuse and infiltrated and ill-defined. But if this is just going to be a brain biopsy case, you can just stop me now. We'll save us all the trouble. As far as vascular, so when I mentioned stroke here, I mean for just a particular vascular etiology of that. We did not see any perfusion abnormalities on our CTA, so I don't think that's likely. Press, so posterior reversible encephalopathy syndrome. This is unlikely as well because usually involves bilateral occipital lobes. We only have unilateral involvement, and the symptoms are usually occurring with concurrent altered mental status. And she does not have any altered mental status and has persistence of her symptoms. And notably, she does have a history of hypertension. Her blood pressure is normal here. You can see it outside of a hypertensive crisis, but still less likely. And then primary angiitis of the CNS. So this is a vasculitis of the CNS. We would see multifocal infarcts in different vascular territories, and we're not seeing a description that would fit that. And so this last category, so here I like to call this the alphabet soup of neurology, and that may be what it's labeled if we're on Jeopardy here, but pretty much all of these are in place still. So multiple sclerosis. So our patient, that was actually the first thing I thought of thinking about this patient and her findings with these relapsing remitting syndromes and fitting some of the demographics. But there are a lot of things that don't fit with multiple sclerosis. And so I started looking at a differential that may account for some of those variations in her presentation, but otherwise present similarly. And then, so that includes tumefactive MS, MOGAD, and then neuromyelitis optica, as well as acute disseminated encephalomyelitis. And then MELAS is the last one, which is actually a mitochondrial disorder. So that involves encephalomyopathy, lactic acidosis, and stroke-like symptoms. All right, so MRI interpretation. So if you're anything like me, like when I saw that this case was focused around an MRI, I just kind of threw my hands up, but I figured it wasn't going to be easy. I wasn't going to get a ultrasound focused case. So stepping out of my comfort zone here, but I always like to ask the how and why of things work to try to get a better understanding of what I'm seeing and what's happening. So I took a step back and looked into how MRIs work. And so I don't see any neurologists around or any radiologists, so I don't think anybody's going to have an aneurysm while I try to explain this. But MRIs are based on the fact that protons within atomic nuclei are normally randomly oriented, and a magnetic field with the MRI is applied to those nuclei and orient those protons now in a directional orientation. After that, a radio frequency is applied that tries to disrupt that alignment. And T1 versus T2 imaging looks at different variations of that RF pulse, both in timing and frequency, and how those tissues respond to that and various phases of relaxation. So different tissues have different characteristic responses in T1 versus T2. So in T1, the dominant signal is going to be fat. That's going to show up as bright on your imaging. As opposed to T2, the dominant signal is both fat and water. It really highlights water. So that's going to be bright on your imaging on a T2 image. So if you look at your CSF, you're going to see that as white. That's a nice way to distinguish between T1 versus T2. T2 flare is a step beyond that, where they actually suppress the CSF signal so you can look at the more abnormal water-based patterns that may be standing out. Diffusion weighted imaging looks at how water traverses across tissues, both within intracellular and extracellular spaces, and kind of that natural diffusion of water. And so if you have more cellular barriers or things that are obstructing that flow, then that would restrict diffusion. If you have a breakdown of cell walls and actually just more extracellular edema that water can easily traverse through, then that may increase your diffusion or so ischemia, cytotoxic edema, where you actually have intracellular edema and ballooning, and highly cellular tumors, those can be things that would restrict diffusion. All right, so what does that mean in conjunction with our patient's MRI? So the way I interpret this now is that we have extensive involvement of her right cerebral hemisphere, as we noted, with some sort of high water content because she has this T2 flare hyperintensity, possibly inflammation versus edema. Notably no mass effect from that though. And then she has diffusion restriction, but she does not have a corresponding perfusion abnormality. So I always tell the residents, look at the images yourself. So I actually put together most of this cases without access, most of the case without access to the images. And so it's very difficult just going off of the description itself, but now being able to look at the images too, there are a couple things that stand out that are not really highlighted in the report itself. And I think one thing to my untrained eye, and I could be wrong with this, but it looks like there's predominantly cortical involvement. If you look at the hyperintensities, it looks like it's involving the cortex and potentially some gyral swelling, and predominantly on their right side. They do mention that there's potentially evidence of the left occipital and temporal junction. I think that's probably right here is what they're noting, but otherwise we see it most based in the right cerebral hemisphere. This actually would go against some of the things that I mentioned in my differential, like MS and those along that spectrum, because if this is more cortical based and involving gray matter, that's MS, and those diseases are likely to target the white matter that are going to be more heavily myelinated. Speaking of MS, so multiple sclerosis, the first thing we'll talk about. So this is the most common autoimmune demyelinating disease. Most cases are relapsing remitting with partial resolution. As we learned, this is a higher propensity for women and an age range that's just a little bit younger than our patient, but still fairly young in general. Typical symptoms that she's presenting with that align with MS is the relapsing remitting nature, except for this very acute phase, which is hard to discern. But prior to this, she's had those symptoms that have come and gone. She has both sensory and motor symptoms, potential for optic neuritis, though she doesn't have the pain with eye movements or any ocular deficits. And then she has what you could describe as focal aware seizures, which are common with MS, and then spasticity as well. What's atypical, the list is a little bit longer, is that this is polysymptomatic. We talked about how it's affecting multiple different neurological levels in different areas of her body, instead of a monosymptomatic presentation. And she has higher cortical dysfunction as well, like aphasia and confusion, which you don't usually see with MS. The rapid onset of symptoms is interesting too. So the fact that this happened while she was doing chores and very acutely actually is more consistent with something that maybe like ischemia. And then she has an extensive MRI lesion, which is not likely in MS. They're usually smaller, more discrete, and in certain particular locations. Also with MS, you'll see bowel or bladder dysfunction, especially with transverse myelitis, so symptoms that would transect to spinal cord level, and then that would also have concurrent bilateral symptoms below that level, which hers are just unilateral. And then no internuclear ophthalmoplegia or nystagmus. So just looking at quickly at the criteria, 2017 McDonald criteria for MS, I would say she has more than 2 clinical attacks with the recurrent nature that she's had over the past few months, but she really only has 1 discrete lesion on her MRI. And so if we look at that, we have dissemination in time, but not dissemination in space. So we would need a different site to be localized either by her symptoms or by MRI imaging. Now, tumefactive demyelinating lesions. So this is something I thought about a lot before seeing the images because I thought it was fairly consistent with our patient's presentation. And this is where you can have a large mass-like lesion, usually greater than 2 centimeters. And there's common association with MS and some other syndromes that we'll talk about as well. And the mean age is right on the money for our patient, 37 years old, and a little bit higher ratio of female to male. Typically polysymptomatic like our patient, motor cognitive, sensory dysfunction, and you can have the higher cortical dysfunction like aphasia and then the seizures. And most common symptom is going to be hemiparesis or hemiplegia like our patient. Most are supratentorial, but they usually have a predilection for the frontal lobe and parietal lobe. Ours are a little more posterior than that. And then you'll see a hypoattenuating area on your CT that corresponds with those MRI lesions. Approximately half of these lesions will have enhancement, usually in the form of an open ring that faces the demyelinating portion. And this is an example of what that looks like. So this would have been interesting to see, but not quite what our image correlates with. So acute disseminated encephalomyelitis. So just thinking about other once again, other disease processes that may present like multiple sclerosis, but to account for those variations. So this is also known as post-infectious encephalomyelitis. So usually occurs after an acute illness or even a vaccination, and it's more common in children, but you can see it in adults. And once again, our patient loves being the textbook for mean ages at 37 years old. So these kept jumping out at me, maybe red herrings, but more common in children, like we mentioned. This will have multifocal neurological symptoms like our patient with encephalopathy. She has had intermittent episodes of encephalopathy, but none currently. And then you'll also see pyramidal signs, motor deficits, brainstem symptoms. And then the MRI findings tend to be bilateral and asymmetric. So ours are unilateral. So not really fitting with that unless there is truly involvement of that potential portion of the temporal and occipital lobe they mentioned on the left side. And then you can have peripherally restricted diffusion like our patient. You will see some generalized slowing like our patient had, and then potential for epileptic form discharges. And this can be seen, ADEM can be seen by itself or as a subset of manifestations within MOGAD or neuromyelitis optica. So there's not a well-established clinical criteria for adults since most of these are dealt with in children. But looking at a kind of a clinical consensus, you have a first multifocal CNS event with presumed inflammatory demyelinating cause, which you could say fits our patient. Common clinical features are pyramidal signs, which she does have some with the spasticity and the weakness. Brainstem symptoms, potentially based on some of her neurologic findings with the hearing and maybe the eye complaints, and then encephalopathy, which she doesn't have currently. And then the MRI lesion is usually diffuse, poorly demarcated like ours, but the key word being diffuse and involving the white matter predominantly. You can see gray matter involvement as well. This is more so a diagnosis of exclusion, though. You want to rule out other inflammatory demyelinating diseases and encephalitis of other causes. So neuromyelitis optica spectrum disorder. So this is where that aquaporin 4 antibody came in play. So obviously somebody much smarter than I am already put their hands on this case and ordered that, because I wouldn't have thought about this before looking into this antibody. But this is a fluid demyelination, usually involving spinal cord segments and the optic nerves. It has to do with areas that are more heavily coated with these aquaporin 4 receptors. So that's more so astrocytes. And one syndrome you can see is this area postrema syndrome, which leads to intractable nausea, vomiting, and hiccups, which our patient does not have. Now, the female to male ratio of this is 10:1. And once again, our patient falls right within that mean range of 32 to 41. Usually you'll see bilateral or rapidly sequential optic neuritis with severe vision loss, which she does not have on our eye exam and per symptoms. And then transverse myelitis, which once again, her presentation is not consistent with. You'll also see, like I mentioned, brainstem syndromes, hypothalamic dysfunction, and maybe in CPRESS. CSF abnormalities are very common, pleocytosis being the most, and the brain MRI usually starts off as normal, but can have abnormalities, especially in the brainstem, hypothalamus, and subcortical white matter. So here's a chart just from UpToDate that just hones in on a diagnosis when you have a negative antibody. And just kind of the hard stop to begin with is that at least one core clinical characteristic must be optic neuritis or acute myelitis or area postrema syndrome. And she doesn't have any of those so far. If we get further workup and we find that she has imaging consistent with optic neuritis, then that may be something to reevaluate. But I won't go through the rest of these, knowing that you have to have at least one of those to start with. So MOGAD is kind of a cousin to neuromyelitis optica in my mind. So median age is 20 to 30 years old, equal ratio female to male. These patients have polyfocal deficits, and some of the core clinical characteristics, like we've mentioned a few times before, is optic neuritis. ADEM can be seen here as well, transverse myelitis, and something unique is cerebral cortical encephalitis, which I thought was interesting. So usually this presents with a unilateral cortical encephalitis, and you could have seizures, aphasia, stroke-like episodes, headache, and fever. Now, our patient has most of those, except for the headache and fever. Interestingly enough, she denies headaches, but most of the things we've talked about and most of these neurologic complaints, I think, would be associated with headaches. So I'm not sure what to make of that. I'm not sure if there is an issue with language barrier. She is Spanish speaking, or what the breakdown is there, or if she truly doesn't have headaches, which would be interesting. On imaging, you're going to see T2 hyperintensity, some cortical swelling, and leptomeningeal enhancement, which was something that they noted possibly being there on the MRI, the leptomeningeal enhancement. There's an interesting acronym, FLAMES, which is unilateral cortical flare hyperintense lesions and anti-MOG associated encephalitis with seizures. I'm not sure why people didn't want to write that out every time they wanted to mention it and made that acronym, but yeah, that's quite a mouthful. That's actually something that's fairly consistent with our patient. Like I said, the thing that's lacking is headaches and fevers. When they talk about seizures, seizures are quite common, and what they're noting is focal motor seizures like our patient. Approximately 50% have a CSF pleocytosis, so a lymphocytic predominant pattern can be seen. And then oligoclonal bands are typically absent. This helps exclude multiple sclerosis. The diagnosis involves the presence of a core demyelinating event. So that could either be ADEM or cerebral polyfocal deficits like our patient has, or cerebral cortical encephalitis. And then you have a positive antibody test while excluding other more likely diagnoses. So this is an MRI that corresponds to potentially that FLAMES acronym, and what you may see in MOGAD with the unilateral cortical encephalitis. And to my untrained eye, it's fairly similar to what our patient has with that cortical involvement and some of that swelling that we're seeing. This chart just kind of highlights the differences between these three different demyelinating diseases. What I'll point out is that MOGAD and neuromyelitis usually have moderate to severe attack severity, similar to our patients, while MS is more milder. Recovery from attacks in MOGAD and MS is usually good, similar to how our patient had her attacks for over the past few months, while neuromyelitis is often incomplete, which this acute phase, that may be what we're encountering here, incomplete resolution. So next, we're going to move on to a mitochondrial disorder, which is very consistent with our patient's presentation. So this is mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. So this is a maternally inherited mitochondrial disorder. It's actually the most common from what I was seeing, and estimated to be up to 1 in 4,000 people having this defect. Usually we'll see this in children ages 2 to 15, but it can happen in adults as well, usually before the onset of age 40. And they'll have recurrent stroke-like episodes with encephalopathy, myopathy, headache, and focal neurologic deficits. So our patient, once again, fits that without the headache though. You may see developmental issues as well, like short stature, hearing loss. They'll have early onset diabetes, which our patient does have diabetes. I'm not sure when it was diagnosed for her. And then you'll see headaches in conjunction with these vomiting in conjunction with the migraine-like headaches. Stroke-like episodes, you'll have hemiparesis and then usually visual deficits involved with that as well. Does not follow vascular territory, no vascular occlusion seen, similar to our patient. So a stroke-like presentation without an actual vascular related insult. Notably, you'll see a persistent lactic acidosis in the serum that does not result in systemic metabolic acidosis. So that's what we had with our patient, which is interesting. You'll also find this in the CSF, elevated lactate level as well. Common MRI findings are cortical areas resembling multifocal infarcts. So there's a preference for the occipital and parietal lobes, and restricted diffusion can be seen. So notably, I mean, our radiologist report did not specify that she has acute infarcts in those areas, but some of the changes we can be seeing with the T2 hyperintensity and the edema and swelling can be seen with early infarct. EEG typically, from what I understand, will have epileptiform spike discharges, which we did not see. I'll also note that the patient, so she did not have any developmental issues. It sounds like she does have diabetes, but her family history was also unremarkable. She has a sister that only had asthma and her mother with breast cancer, but no family history of seizures or anything that would be consistent with this type of presentation. So the literature was a little sparse on this and trying to come up with a consensus on a diagnostic consensus. But as far as the next steps, possibilities include identification of the transfer RNA gene mutation. You could do a muscle biopsy for the ragged red fibers. And then if you check the CSF, you may see elevated lactate and pyruvate levels. And you may also see that elevated pyruvate in the serum as well, in addition to the lactate we saw. MR spectroscopy can be used to identify a lactate peak. And then last, I want to talk about Creutzfeldt-Jakob disease, because we'd be remiss if we didn't discuss it with her acute deterioration. So this is a prion disease where these infectious protein-containing particles overtake normal proteins and lead to neurotoxicity. The majority of cases are sporadic, so 85 to 95%. Even though you hear in the news about mad cow disease when it happens, most of these are sporadic. It can happen at basically any age range. The mean age though is 62, so older than our patient. And the thing that doesn't fit with our patient is that typically you have a rapid neuropsychiatric decline. So from our history and physical, it doesn't seem like she has a neuropsychiatric implications with her disease process. And you'll see behavioral abnormalities, higher cortical issues like aphasia, frontal lobe syndromes. And I found a study that showed that's looked at 248 patients with sporadic CJD, and neuropsych symptoms were present in 96% of them, with most common symptom being amnesia and impaired attention. So I was trying to figure out if you could have this presentation without the neuropsych implications, which would be very unlikely. Myoclonus is very common, similar to what our patient is experiencing. Greater than 90% will experience this. And then CSF studies are typically normal, similar to our patients. Periodic sharp wave complexes are common on the EEG, and so we do not see those. Neuropath, so about a brain biopsy is going to be the gold standard, but there's this real-time quaking-induced conversion test of the CSF, and that's the most validated test. It's my understanding there's only like 1 or 2 places in the country that will check that. 1433 and tau protein can also be checked, but these have a little higher false positive and false negative results. Your MRI is actually, and this is why I was a little bit concerned with our patient, is very consistent with what we're seeing. So T2 and T2 flare images, as well as diffusion weighted images, involve the cerebral cortex, and you'll also see the caudate and putamen, which we don't have. So the CDC has some diagnostic criteria for probable CJD, and so more of a slam dunk diagnosis would be a neuropsychiatric disorder plus that positive quaking test. Otherwise, you can use this combination of findings, and first and foremost being rapidly progressive dementia. So that needs to be present, but then that plus at least 2 of these characteristics that they note. And then positive studies, which could be either an EEG, the 1433 CSF assay, or the MRI, which in our patient is positive according to this, with at least 2 cortical regions involved. But the key words being that the progressive dementia or neuropsychiatric component need to be at play here. So all that being said, what do we think the diagnosis is? I think the door is still open for a few of the potential diagnoses. If I had to pick one, my clinical suspicion would be highest for MOGAD with that unilateral cerebral cortical encephalitis. I would start with that workup by a neurology consult, please. I'm in way over my head here. And I surely wouldn't have had weeks to look at this on the wards like I did right now. An MRI orbits and spine would kind of complete our workup for demyelinated disease, MOG antibody testing, and then CSF analysis, which we've already have CSF studies. We can check for oligoclonal bands to rule out MS. That being said, I also still have concern for MELAS, though it's an atypical presentation usually seen in childhood. And she doesn't have a family history for it or developmental issues. She does have stroke-like episodes, the persistent lactic acidosis without a systemic metabolic acidosis. And so I would check the CSF for elevated lactate and pyruvate. We can check the serum pyruvate levels as well. And then you can pursue MR spectroscopy looking for that lactate peak. I think these would be the kind of the more low-hanging fruit for assessing this. And then I would go back and probably do a better neurocognitive assessment of this patient, make sure there is no neuropsychiatric decline that may be indicative of CJD, and an easy test for more so of a screener would be that 1433 CSF assay. That's all I have in my million references.
Hang tight 1 second. Excellent talk. Let's get this. Here we go, I think. Is that up and running? Okay. Want to come up and present your expert view? All right, come on up.
Hi, this is Dr. Akay. I am a clinical geneticist. Actually, I am very, very new to the Richmond and as well as VCU. Just moved like 2 months ago. And as you imagine, very excited to be in here for my first talk. In this case, I think this case was taken care of our previous biochemical geneticists with Dr. Al-Sahif and your wonderful team, and everything was done perfectly. And when they consult this patient, Dr. Al-Sahif has also high concern about the meal loss, and we order a mitochondrial gene sequencing, and we show the mitochondrial variation that can support the meal loss diagnosis. So yeah, you are right. So, and it was a not easy case. So what I would like to do on my presentation, so I would like to start with especially this terminology, stroke-like episodes, equal to the metabolic strokes. So which means if you have a patient with the acute neurologic some deficit, with the lesion distribution inconsistent with classic vascular territory, which we saw your patient, right? It wasn't like thrombotic, it wasn't like any kind of ischemic lesions, and it wasn't like regularly you are seeing this kind of. So this is the first thing. The second thing is, I think important thing with, if you are like a stroke-like episode, it begins with metabolic dysfunction or insufficiency for the cellular energy level. And it's mostly usually caused for the trigger one event, like it could be fever, vomiting, something. This case, I think we didn't have that, still possible, but we know that this patient had some underlying like a diabetes, right? And maybe it was the like triggered. So there should be some trigger to starting to this stroke-like episode. And let's go here. Okay, so for the metabolic strokes, mitochondrial disorders are the most common one that we are seeing the stroke-like episodes. And the most common one that you also mentioned previously, it's a meal loss. But there's other types of mitochondrial disorders that can cause the similar kind of presentation, but they are, for example, Leigh syndrome. They are pediatric patients. We are not seeing adult. They are mostly hypotonic, like cancers, mostly ophthalmologic features. And for the meal loss and the myoclonic epilepsy with regulatory fibers, actually very confused with the clinical baseline. They look like each other, but for the MARF, you are seeing the myoclonic seizures. So for the meal loss, it was mostly focal seizure, whatever area is involved. For the MARF, it's myoclonic. So you can like distinguish with the clinic base with this basic, and there's other also differentials other than this one. So before I trained as a pediatrician, and before I started the genetic clinic and education, I always thought about like we are seeing the metabolic disorder pediatric patient, right? And we have a newborn screenings, we are catching that one, and that's it. And the adult patient, I never, even my teenage like patient, I wasn't thinking about the newborn or metabolic disorders very so much. But after like being in this area and seeing different kind of presentation, just one takeaway point from this presentation: if you have a patient in your hands without an unknown reason, unknown something, etiology, think about metabolic. The metabolic disorders can present any age, and because with a milder presentation is always in there. For example, urocycle disorders can cause altered mental status, and we had a patient like 60 years old that diagnosed mild type autism deficiency. So like a congenital disorder of glycogen disorder, very complicated, can present, mimic everything. Or organic, some of the organic acidemia same way. So there's a broad, and you can think about metabolic disorder in adult if you have some unknown etiology. So So I would like to go like fresh your mind about mitochondria to better understand what we are doing. So these mitochondria, little tiny battery cells, are all like everywhere other than the except motor red blood cells, right? But they are different. We have one nucleus, but we have a multiple hundred thousands of mitochondria each cell. So which means that we have a different kind of presentation in the cell because they are not one, they are hundreds and thousands based on the what the energy level that the cell needed. And they have the only organelle other than the rugula has a DNA, and which is making them very unique. So this is the basic differences between nuclear DNA and mitochondrial DNA. So the thing is, we know like we inherited our mitochondrial DNA from our mom. Why? Because when the fertilization happened, or sperm has the DNA on the tail and it's just losing, and you will have just a mom. But the nuclear DNA has you are inherited from both of your parents. Second important thing is the mitochondrial DNA, as you are seeing in this slide. It's coding 37 genes compared to like a nuclear DNA 20,000. It looks like, oh, they're not important, right? And it's just a 37 genes, but it's not. So mitochondrial DNA even has coding like 37 genes. They are having a 33% of coding sequence, which means whatever they are coding, it's turning to the protein, and it's important. And when you look at like a nuclear DNA, it's just a 3% of the like we have a coding. And the thing is, for the DNA, like mitochondrial DNA, they don't have a repair or proof mechanism, so they are very prone to mutation than the nuclear. So I wouldn't go this exhaustive slide. My main goal is to understand mitochondrial pathway is very complicated. And as you are seeing in here, for this beautiful, like for this beautiful pathway, you need not just only mitochondrial DNA, you also need a nuclear DNA presentation. So mitochondria without a nuclear DNA, they wouldn't replicate or the pathway wouldn't work, which means the clinical application. If you have a case which is not like we call like maternal inheritance pedigree, that doesn't mean you don't have a mitochondrial disorder. That means that maybe there's a nuclear DNA mutation that causes the mitochondrial disorder. So it could be present any inherited patterns. Expectation is maternal inheritance, but could be also the nuclear. So the most important things, and I will link for the clinic as well. So when you have a mutant like mitochondrial DNA, clinic variability change for 3 different ways. One of the thing is as we say that we have tons of hundreds of like mitochondria in our cells, and it is if you have a mutant DNA and you have a different kind of proportion in here. We are calling it as heteroplasmy, which means you have the normal and mutant DNA in the same cells. And this is like one of the things we are seeing a different clinic presentation in the mitochondrial disorders, and which is making them very unique. The other thing is the tissue distribution. So for the mitochondrial DNA, every tissue has different kind of mitochondrial load. For example, brain use energy more, so they have a more like a mitochondria. And when you look at, for example, one sample from the brain mitochondrial DNA, you will see high heteroplasmy. But if you look at the blood, maybe we wouldn't see that one or less likely. So the tissue heterogeneity with the heteroplasmy. And other thing is the threshold. So every tissue, so we don't know actually what is the threshold. So there is not like set up thing that you are gonna say this percentage of heteroplasmy will cause this disease. And this one is that is not something like that. Sometimes you are seeing the clinic presentation, 10% of the variant, sometimes you are not seeing 30. So we don't know why and how it's happening. This is the very tricky part for the mitochondrial disorder. And the other and the last one important is when we are like, you have a mom with no symptoms or mild, some symptoms have some kind of mutant DNA. When it is getting the oocyte, like primary oocyte, mother mitochondria going like selectively to each one. So it is randomly selected. And it means that when you have offsprings with the same mom, you can see different kind of level heteroplasmy, which means that you can see a very phenotypic differences in the same family with the same mutation because of this level differences. So this is the one case, all this that we learned from the basic genetics. This is the sample of pedigree for one family with 3 tested positive for mitochondrial gene, which is cause of MELAS. And 3 of them has the same mutation, and 2 of them is like affected, like has some kind of symptoms. The index case was in this pedigree was mom. The mom has a long-standing diabetes history, starting 45 years old. It is not in the pedigree, but reported in this report, has a sensory neural hearing loss, developed progressive ataxia in her 60s, and after multiple stroke-like episodes, and died 75 years old due to renal failure, and ended up with a MELAS diagnosis. And after her presentation, his true son tested positive for this same mitochondrial variant, and one of them is affected. She started her first stroke-like episode 44 years, and currently, I think, following. And the other one is currently asymptomatic, only has a diabetes. So, and we are calling, if you have this mutation and just diabetes or sensory hearing loss, we are going to milder MIDD. And when you look at the heteroplasmy level, mom has a 10 percentile, right? The affected son has 14, and the other was a 17. So your expectation was the 17 ones should be a more symptomatic, right? So that is the basic tissue change, like tissue differences. Heteroplasmy is not same in every in the tissue. This test was done from the blood. So we don't know, maybe unaffected patient, very low heteroplasmy level on his brain cell or muscle cell or other. So this is something that I would like to point. So the real world, like mitochondrial disorders, could present any symptoms, any organ, any age of onset, any timeline for progression. So mitochondria is aging organelles. And when you get age, you can see the dysfunction. So you can expect like a progressive kind of symptoms very later age. And as I mentioned, any inherited pattern. So for the MELAS, yes, it was described in 1984 from the Columbia's pediatric neurologist. They saw a 2 individual different 2 and 9 years old kid with a short stature, seizure, hemiparesia, hemonopsia, and cortical blindness. And they say that this should be something new that we are not seeing previously. And they describe in these 4 initial letters saying that there is a mitochondrial myopathy, encephalopathy, lactocalcidosis, and stroke-like episode. And this is the first time they diagnosed. And at that time, the original diagnosis, we were thinking that we are just seeing the MELAS in the kids. But for the MELAS clinic presentation is mostly in energy dependent organs, brain, skeletal muscle, heart, pancreas, and the inner ear. These are the most important organs that we are seeing the symptoms. And based on the affected tissue, you are seeing the different kind of symptoms, but the main ones are mostly more high energy dependent organs. So age onset, 2 years to 70 years, anytime. And the typical symptoms, especially for the pediatric presentation, we are mostly seeing a stroke-like episode. And in this, your presented case, these episodes are spontaneous, suddenly happen, mostly reversible, and they have a stroke-like lesions, specific stroke-like lesions in the MRI. And they are very recurrent. If you are seeing one patient, that kind of symptoms in the MELAS, you are expecting to see again. I don't know how often, how frequency, but they are repeating. And that kind of episode also causing brain dysfunction, atrophy, and it's slowly progressing. So for the MELAS patients, they are early ages, developmentally normal. But based on the affected stroke-like episodes, they are having some kind of symptoms or a developmental regression. Yeah, same in the adults as well. So they have an encephalomyopathy. So the myopathy part, I would like to highlight that one. So for the muscle is one of the most effective organs. So the patient, especially adult patients, are mostly coming fatigue, exercise intolerance. And some of the patients also present with rhabdomyolysis. So rhabdomyolysis, if you are seeing in adult patient, with triggering some event for the stress or infection, think about the metabolic. Most of the time we are taking fetal oxidation disorder, but the mitochondrial is also one of them. And seizures, as I said, mostly focal, and it is based on how the involvement in the brain area. Hearing loss is very common. We are less seeing sensory hearing loss in the kids later onset, and this is mostly with the adult population. And they have some visual impairment, retinal dystrophia, and cortical blindness with the stroke-like episodes. Diabetes is one of the most common symptoms in adult age that you need to see. Lactic acidosis, that is one of the reasons this patient, I think, going through the MELAS pathway. It is with the stroke-like episodes, you are seeing the lactic acid in the blood, but when you are if you look at with the patient without a symptomatic time, you might sometimes you wouldn't able to catch the lactic acid. So if it is in there, it is really diagnostic, but if it is not in there, you wouldn't completely rule out. The main thing that we are seeing CSF level and with the MR spectroscopy, most good presentation. You need to see lactate peak every time, affected and unaffected brain MRI. You need to see the lactate peak for the MELAS. They have a recurring headaches that our patient doesn't, I think, but headaches are one of the important part and one of the description of the patient will develop stroke-like episode. If there is a recurrent headache worsening, not able to treat with regular medication, this means that the patient will more prone to do developing his stroke-like episode. So the other one thing that we are currently most seeing, this patient has mostly severe constipation. And if you are seeing MELAS patients, severe constipation, aggressively treat that one. Constipation itself triggering the stroke-like episodes. And there is not very specific labs for the MELAS. Lactic acid is good. You can see lactate pyruvate increase, and plasma in the plasma amino acid, we are seeing the high allele level, which is reflection to the high lactic acid cell. So there is nothing very specific in metabolic lab that we are looking for the lactate. And this is a pathophysiology of MELAS. There is not consistently known something, but there is impaired like energy protection is causing oxidative stress, low citrulline, low arginine level, and they are decreasing the nitric acid level, which is making there was a constriction. That is the one reason that they are thinking we are seeing the stroke-like episode. The other theory is mitochondrial proliferation making endothelial dysfunction. That is the thing. I wouldn't go through all things because, yeah.
We're a few minutes over, so maybe we have 5 more minutes. If anybody has to run, we're about 10 minutes after. Sorry, we don't have a clock.
Okay,
So
sorry. Yeah,
we'll take 5 more minutes.
Yeah.
If anybody has to run, we understand. Thanks.
Okay.
So this is the MELAS imaging, as we previously already mentioned, has the increased T2 signals, do not corresponding to vascular region, and mostly with affected cortical areas, and sometimes involve the white matter. It is asymmetric, can migrate, fluctuate, or even disappear over the time. And mostly, predominantly occipital, parietal, and the temporal region is less likely to be in frontal. And this is the MR spectroscopy. You are seeing the lactate peak, and compared to like this is a creatine, and this is the acetyl aspartate. This is the low. So this is a significant diagnostic criteria for MELAS. If you are a suspicion, get the MR spect. And diagnoses are mostly with the clinical features plus the mitochondrial DNA variant analysis. You can do it very simple. If you have a high suspicion, have a MR spec with the high lactate level. If you are not finding in the blood, you can send urine. We are doing urine mitochondrial testing. You can send buccal swab or any other tissue sample, so we can diagnose. This is the most seen variant in the MTL1 genes, and for the MELAS, 80% of a patient has this mutation, very common, that our patient also has this same mutation. And there was other genes that we are seeing as well. I just would like to point, and as we have not too much time, this is a recent study published like a September, I think, very, very recent. They did a very big meta-analysis for the adult patient with the MELAS, and they tried to compare what is the features. As you are seeing, there's a different cohort. I wouldn't go deep dive, but the diabetes, sensory and hearing loss, myopathy is the most of the symptoms that the adult presenting, and this stroke-like episode is a little bit lesser than the pediatric population. And the criteria for the MELAS is getting outdated. So recently, this North American Mitochondrial Disease Consortium present this new clinical diagnostic criteria that you are seeing. It is more complicated. They are looking to cardiac features, others, and if I wouldn't go through this one because this is not universally accepted now, but I'm hoping that with increased knowledge, we will have more better diagnostic criteria, both pediatric and adult presentation. And that is one of the other example I would like to show you, like for the MELAS, 46 years old male, diagnosed previously type 2 diabetes, and just came with the chest tightness, and has also 1 year of like a sensory hearing loss, and at the end diagnosed with MELAS. So MELAS is could be a occult like adult presentation disease. No significant diagnosis that we are saying. Regular standard treatment for the features. Use valproic acid with a precaution for the seizure. There is not a contraindication, but one of the other mitochondrial disorder, which is a POLG mutations, we saw the like encephalomyopathy with the valproic acid. So if you have a better choice for treating the seizure, choose that one. Avoid this one, valproic acid. There is no diet restriction. The other metabolic disorder, we have some kind of restriction, but no diet restriction. Sometimes we are using ketogenic diet for refractory seizure patients. And for the hearing loss, as the aminoglycans are the mitochondrial toxin, avoid them. And for the diabetes, because metformin itself can cause a lactic acidosis, sometimes like for treating this patient, there's not too much information about that one. Because like metformin is the first choice for diabetes and most of the MELAS patients are using it. There is not a good correlation, but that is something that you maybe keep on mind. So for the acute stroke-like episode, and this is not also robust treatment option, but what we are doing, we are giving a bolus intravenous L-arginine. As I discussed with the pathology, the L-arginine level is when getting low, it is decreasing the nitric oxide synthesis. So, and our game is increase the nitric oxide and make a smooth muscle dilatation. So we are giving this L-arginine as soon as possible within its first symptoms, and we're following up with the continuous infusion next 3 to 4 days. And even there is not a consensus about that one, chronically, we are also giving L-arginine and citrulline supplementation for the MELAS patient and chronic studies. So like we are also giving a patient like emergency letters for this patient. We are saying that if you have a not fever, not feeling very well, go to the urgent care or seek a evaluation. The thing is, if you are like, I'm not so sure of how many patients you are seeing the metabolic in the adult presentation. And if it is coming with the letter saying that I have this diagnosis, my doctor tell me if I am not feeling well, go there. The main goal is we would like to reduce the metabolic stress, because we know that if these things are getting worse and they are gonna go this stroke-like episode. So we would like to treat everything very aggressively, and we are just starting for them like an IV infusion. This is not, we are treating the dehydration. We are intent to deter the catabolism. These patients need like a food, like glucose. If they are not getting enough, and their mitochondria are not working very well, they are very easily getting this catastrophic stroke-like episode. So always, if you have a MELAS patient came with a fever, any mild illness, don't hesitate to give a fluid. We are not using lactate ringers for these patients. But if there's like a sepsis kind of stuff and the lactate ringer is better, you can use it. There is not too much information about that one as well. Feeding is so important. So feed them if they are not eating very well. We already talked about, and I would like to point in there, even though lactic, we are not seeing metabolic acidosis with the MELAS patient. But if you have a renal involvement for this patient, they are also losing like like they will more prone to the having metabolic acidosis. If you are seeing a acidotic level, treat with the sodium bicarb with them. And for the mitochondrial cocktail, you can give it. There is no harm, but studies not show the positive improvement with the mitochondrial cocktails. And these are the like mitochondrial toxins. There's again not a robust strict contraindication, but try to be avoid mitochondrial toxin, especially valproic acid for the seizures. And if your patient will go to do like a surgery or something, we are using propofol with caution. It's causing the mitochondrial toxicity as well. So it's very highly heterogeneous and variable even with families. Symptoms vary, single organ or multiple organ, change by time, and diagnosis should be confirmed by genetic testing. And if you are looking, you are seeing that one for the metabolic disorder. That is all that I have. I know that I passed my time, sorry.
Thank you, Dr. Akay.
Thank you.
Any questions, folks?
So probably the best way to get someone about it is see you with your clinical.
Yeah, it's good. Like, yeah, it will be. Yeah, it's good. But the main point is, I think, for as an internal medicine person in here, if you have any concern about any patient, metabolic disorders always your like this differential. Some metabolic disorders should be in there, because as we are having more access to do metabolic testing and genetic testing, we are seeing actually they are also like in the adult population. So if you have any concern, don't hesitate to refer to us, consult us, call us. Basically, ask, is that okay to send some metabolic test for this patient? Is that any? We will say yes. So yeah, definitely refer to that patient. But the thing is, we are giving an emergency letter. So when you are seeing that patient and say that, like, give the fluids, they don't look like dehydrated. Why I'm gonna give fluid? There is always for metabolic position, or main goal is prevent them to like catabolic state and start the treatment, hydration, fever, antibiotic, everything earlier as much as possible.
You see the patients now, patients are
I am seeing, like I am the only geneticist currently. I didn't do any biochemical fellowship. So I am the like looking adult, pediatric, prenatal, inpatient, outpatient. I'm everyone. So I'm the one currently. Hopefully we will planning to hire more person, but currently, yeah, I am.
what happened with the patient?
What's that?
What happened with the patient?
Died.
What happened with the patient?
Yeah. Yeah, so when I look at like a chart, because this wasn't originally my patient, so I was wondering what was the story. And I look at the chart and openly say that this is, but I didn't see any note on the like system, so I don't know what was the reason, what happened. But the only thing that I know, we recommend the familial testing for this patient, looking to like maternal side and other, because this is a mitochondrial, not a nuclear. I think they didn't turn back to our genetic counselor, and I'm not so sure what happened.
Thank you both, appreciate it. Thank you, Dr. Akay. Appreciate it. Yes.